Ventricular septal defect. What is ventricular septal defect? Congenital ventricular septal defect occurs as a result of incomplete septation of the ventricles. Most congenital defects are perimembranous, which means the defect is at the junction of the membranous and muscular portion. Pathophysiology. In small defects, which are usually less than 0.05 square centimeter, the size of shunt is determined by resistance at the defect. Small defects result in small shunts. If the defect is large, both the size and direction of the shunt are determined by the relative resistance in the pulmonary and systemic circuit. As long as pulmonary vascular resistance is lower than the systemic vascular resistance, the shunt is left to right. But if pulmonary vascular resistance rises above systemic vascular resistance, then the shunt reverses, which means it becomes right to left. Large defects tend to result in pulmonary hypertension. The size of left atrium and left ventricle is directly proportional to the size of left to right shunt. Right ventricular enlargement occurs only when pulmonary vascular resistance increases. Pulmonary hypertension may lead to development of pulmonary vascular obstructive disease and reversal of the shunt, which is called Eisenmenger syndrome. Clinical features. The symptoms of ventricular septal defects are: if the defect is small, it is usually asymptomatic. If the defect is large and pulmonary vascular resistance is not significantly elevated, then growth failure occurs, congestive cardiac failure, and repeated respiratory tract infections may occur. If the defect is large and pulmonary vascular resistance is high, then shortness of breath, dyspnea or difficult on exertion, and cyanosis may occur. The signs of ventricular septal defect are: prominent apex beat occurs, then systolic thrill in lower left parasternal area is seen, pansystolic murmur in lower left parasternal area can be heard, and if reversed shunt develops, which is called Eisenmenger syndrome, central cyanosis, clubbing, features of heart failure is present. Investigations consists of ECG, which is normal in small defects, but in large shunts results in left atrium and left ventricular enlargement. In the chest X-ray posterior anterior view, we can see that there is enlargement of main pulmonary artery and left atrium and left ventricle with increased pulmonary vascular markings. In echocardiography, we can see that left atrium and left ventricles are enlarged. We can visualize the defect directly, and color Doppler demonstrates the flow across the defect. Treatment options are medical and surgical. In medical treatment, no exercise is restricted in the absence of pulmonary hypertension. which means if pulmonary hypertension doesn't occur, we do not restrict any exercise. We have to maintain good dental hygiene of the patient, and antibiotic prophylaxis is done. Chest infection and congestive cardiac failure should be treated if present. Adequate nutrition has to be maintained. We have to do surgery when symptoms are not controlled medically. Infant between 6 to 12 months of age with large defect with pulmonary hypertension, even when symptoms are controlled. Also, when large ventricular septal defect and congestive cardiac failure is not controlled by decongestive therapy. After 1 year of age, significant left to right shunt with QP by QS of more than 2:1 indicates surgery. Older infants with large ventricular septal defect and increased pulmonary resistance should be operated immediately. The underlying condition for ventricular septal defect are Down syndrome in tetralogy of Fallot patient and tetralogy of Fallot patient, and infant of diabetic mothers are susceptible of ventricular septal defect.